Good afternoon, everyone. Myself, Dr. Vinod Kaushik, with Dr. Sonil on the behalf of IAP India Digital Team, just welcomes you all for the today webinar topic, Sensorimotor Adaptation and Learning Approach in a Post-Critically Ill COVID Cases by Dr. Veena Kumar. Today, the webinar is organized by IAP Women's Cell and IAP Haryana team. And I just shows my gratitude to our Dr. Sanjeev Keja, IAP President, and Dr. Ruchi Vashnai, IAP National Women's Cell Head. And today the moderator are Dr. Komal, Dr. Priyanka Rani, and Dr. Neha. And Dr. Komal, she is ma'am is the coordinator IIP Women's Health Panipat branch. She is assistant professor in physiotherapy, FAME Physiotherapy and Rehabilitation College, Panipat. And the other moderator is Dr. Priyanka Rani. She is EC member of IIP Haryana and practicing in the Gurgaon. Now I will just hand over to Dr. Komal. Please continue with your webinar, ma'am.
Thank you, sir. Thank you. A very good afternoon to all attending this webinar on sensory motor adaptation and learning approach in post-critically ill COVID cases. Now, I want to introduce our honorable speaker, Dr. Veena Kumar. Dr.
Okay,
Veena
ma'am.
Kumar has 11 years of ICU experience. He is MPT in cardiopulmonary. Uh, He is a London shoulder clinic expert and tutor. He is the founder of Solace Physiotherapy Center. He is the HOD in Ashlock Hospital. He is the former head in National Heart Institute. He has one publication under his belt at prestigious Elsevier publication. He is the peer reviewer for the Physical Therapy Division for the esteemed Indian Journal of Thoracic Cardiovascular Surgery, Physical. He has 6 citations till now, and he was the physiotherapist of our ex-president of India, late Pranab Mukherjee, sir. We welcome you, sir.
Thank
Now
you.
I am handing over the mic to Dr. Veenu Kumar for starting our webinar. Thank you, sir. Please start the webinar.
Thank you, Dr. Komal. Thank you, Dr. Kamini. Thank you, IAP. And thank you, IAP Women's Cell, Haryana, Panipat branch for having me here. For the today's topic, we are on COVID. And COVID is the much talked about topic in the century. So we are here to discuss the approach, sensoromotor approach on COVID. Right, so I just want to tell you, like, we are witnessing many webinars. There are researches going on, like what to do on COVID, because this is an unprecedented episode, and we are just working on what best we can do to prevent it, to treat it, and to manage it. So I'm not going to talk about what is called COVID and what are this type, because my colleagues, my friends have already discussed that thing. But just want to say some role of physiotherapists in COVID. Like, they say that we are aware about medical doctors and nurses, how they are working on COVID patients, but physiotherapists have a pivoting role in managing COVID patients, and especially the respiratory care therapists. Physiotherapy not only assists the medical team in well-being of the patient, they are also helping in preventing the disease and obviously preventing it going on further on. So the today's topic is sensoromotor adaptation learning approach in post-COVID critical care cases. So we know that there are subcategories like asymptomatic, mild, moderate, severe, and critical. So we are going to talk about critical. So how many patients are, this is just a data from a study, like initial report suggests that only 5% of COVID patients require an ICU. So the median duration from onset of the symptoms to reaching to an ICU is 9 to 10 days. So supposingly if a patient is getting exposed today, so he might not need an ICU. The symptoms maximize at the 8th or the 10th day, and if it doesn't get subside, he or she may need an ICU care. So this suggests that there is a gradual deterioration in an exposed case. It is never an acute case until unless there are other comorbidities like an age which is above 60, or there are comorbidities like diabetes, heart issues, kidneys issues, which account almost 40% of the cases. So, who is said to be critically ill in a COVID-19? So we know that it started from Wuhan and Chinese are on to it. They are having a number of researches. There are maximum number of researches coming from China. So being in China point of view, from their opinion, a COVID patient is considered to be critical if the respiratory rate is more than 30 breath per minute, and there's something called low oxygen index, which can be calculated by partial pressure of oxygen divided by fraction of inspired air. So if it is less than 200 mm of Hg, the person is said to be in a critical zone. And there's a subcategory. If it is less than 150, he needs a venti or an ECMO or prone positioning. But if it is more than 150, so empirically he can be treated with non-invasive ventilation. And now a new method of technology has come, which is called HNFC. It's called high flow nasal cannulation. In this, the company has devised a product from the nasal cannula. You can give an amplified oxygen to the patient to support their lungs. So this is another article from Turkish. So these are the consideration. If this is happening in a patient, he can be regarded as a critical ill patient. So patient with respiratory rate more than 30. If he is having dyspnea or work of breathing is very high, the saturation is lower than 90. If he or she require more than 5 liter of nasal cannulation, if he is hypotensive, the systolic blood pressure is less than 90, if there is hyperperfusion sign, and if there is a sign of organ dysfunctions. So that if the patient is having these categories or these symptoms, he or she is said to be in a critically ill. So what is the prevalence of problems in COVID-19? So as I said that there is a category called organ dysfunction. So we have seen from the recent studies that in a critically ill COVID patients, acute respiratory distress syndrome account almost to two-thirds of the total number of cases. Then you have acute kidney injury, you have cardiac injuries to 23%, pneumothorax to 2%. So this is just the percentage from the recent studies. Still these numbers are changing because every now and then the researches are happening. But it is for sure that a critically ill COVID patient will have acute respiratory distress syndrome. So as a respiratory therapist, we actually deal with acute respiratory distress syndrome. So this is just a small gist that what a care can be given to a COVID patient. So in this, an intravenous fluid strategy is given, an empirical antibiotic therapy. So antibiotic is not a solution for this COVID disease, but empirically means whatever as a symptom, we can deal with it. Periodic prone positioning, an ECMO machine, regular chest and limb physiotherapy, keeping in account of aerosol. So we know that now COVID is an aerosol disease. So we cannot generate an aerosol out of a patient. Otherwise, we are spreading the COVID disease. So we have to be very calculative while managing the patient, right? So now we are on the topic, the what like sensoromotor approach, where to apply. So for that, we need to understand what complication of post-COVID critically ill patient is suffering. So there are two terminologies. One is called PICS and another is called ICWC. So PICS is a small term called post-intensive care syndrome. Now this syndrome has been terminalized for a general well-being of a patient and impairment in physical, cognitive, and mental domains. So this PICS can be very severe and it can really affect the quality of life of the patient. The second most important complication is ICU-AW. So it's called intensive care acquired weakness. It is unprecedented now, but it has been documented that a COVID patient who is in ICU for a long time period, they are they are bound to get weak. So weakness is manifested due to a disused atrophy. They are not in a zone of using their muscles, they are using their activity, so they tend to become weak. But studies say that there are two type of weaknesses. One is called critically ill polyneuropathy, and another is called critically ill myopathy. So polyneuropathy means the patient is weak, the digital extremity is weak, and there is somewhat of sensory loss also. And myopathy implies that he is 110% weak, and especially in the distal extremities, and most prevailing in the lower limbs. So if both of these are happening in a COVID critically patient, so the difficulty in ADL, the activity of daily life, will be difficult for the patient. And now here the therapists come into the picture to bring back their quality of life and to make them a basic activity of ADLs to be improved. So what are the presentation when you have ICU weakness? Normally it is muscle weakness. So predominantly, as I said, predominantly the lower limb. Flaccid weakness is observed, which is symmetrical. Okay, there is no sign of facial weakness. Cranial nerves are rarely involved. Muscle wasting is almost in 1/3 of patients. There are diffuse reflexes. So if we start from the case study point of view, reflexes are present at the early stages, but it gradually goes down. There's a difficulty in weaning the patient from a ventilator if he or she is on a ventilator. There's a sensory loss, as I said, and there's an impaired consciousness. So that can be due to an encephalopathy sign, or that can be due to sedation. So this is a clinical picture in a mostly critically ill COVID case. So now we come to our approach. So this is a differential diagnosis. So other complications can be psychological, it can be cognitive, and definitely QOL, quality of life. So from physiotherapy approach, what should be our approach? So definitely a rehabilitations come into this play, and it is always a multidisciplinary. Work in conjugation with all the team members bring the maximum outcome, optimal outcome in the patient. Now, physical intervention should be started as early as possible because we know the concept of early mobilization. We start at ICU even at the sedation period. If we turn the patient timely, this is again a one side of immobilization only. Now the approach. So this approach we have taken from our own article, which has been published in elsewhere. So we have applied this technique on a TBI patient, and we got a good result. So that's why we are using this technique on COVID patients now, because as I suggest that there is a CPI, a polyneuropathy, and a myopathy. The same approach can be applied on a patient to find out the results. So we'll break the term sensoromotor adaptation and learning approach. So what we say as a motor adaptation. So motor adaptation is like, since he or she is weak now, he or she is not able to perform their ADLs. So a motor system respond to that altered environment. So if I'm not able to reach to my activity, so this is an altered environment for me. If I can make them practice over and over to use that technique, to use that movement, they are said to be adapted. So motor system respond to an altered environmental condition to regain the former level of performance. So altered environmental conditions can be external perturbations, it can be changes in the body. A patient can realize that he or she cannot reach to a glass, or it can be external that, oh, you are not doing the activity. So these two combine together to form an error. So this is an error in the patient because they cannot do that certain activity. But this error is again a driving force for adaptation to a particular movement. If I am aware that I am not able to pick my phone, so that means I will make my strategy to at least do that activity. So in that process, I'm getting adapted to a new pattern, right? So adaptation can occur with practice. So the physical therapist can ask the patient, we'll do an example also, to practice over and over a certain movement so that he or she get adapted to that particular motion. Okay. And it can actually occur in single session. If a patient can get aware about his error, and you can make them aware about their error, and you can ask them to change their strategy, in one single session they can adapt to that particular movement. So, and it is not so that he is adapted to a particular movement, but supposingly if that error is removed from the life and still the patient can perform the activity, he is said to be adapted. Okay. So if the condition is bad, you are making him practice. If he is practicing, he is adapted to it. And if that condition is resolved and he's still able to do the activity, that means he is adapted to that particular movement. So this is called motor adaptation. Now we come to motor learning. So it is the ability to reliably deliver the accurate pattern. Now our first aim was to just pick the mobile phone. So I can make my strategy change and to pick it up. But now I want it to be in a nurture way. I want it to be very smooth and do it effectively, right? So this comes with practice over and over. A particular movement is practiced so that that particular motor pattern is learned by the patient. He was adapted to the motion. Now we are making him learn. So just increasing the accuracy will not help to learn the patient. He or she can learn it, but it has to be very accurate. So accuracy means when you are doing some movement, it should be very accurate. At every time when you are doing the movement, it is accurate. So this is called skill acquisition. So if I supposingly, there's an example. Now I want to lift a glass. I want to lift my phone. Okay. And I have learned to lift it up. So if I keep on doing it, this activity, I have learned this activity, right? But I need to change the activity. My aim is not to lift the mobile. My aim is to teach him reaching activities. So what I will do, this time I'll take the mobile phone up and I'll ask to lift it from up. Then I will ask the patient to lift it from ground, or I can add two mobile phone together so that the weight is increased. So this how we train the patient to learn the particular reaching movement with different systematic changes, right? So as rightly said, it can be achieved only through extended practice and introduction of task complexity. So I'm making the task complex for him. First he was just reaching in front. Now he's reaching from the top. Now he's reaching from the ground. Now he's reaching on two mobiles. So this is how we are adding on the complexities. So this now, now come the part of sensory. Only motor adaptation and motor learning will not solve our purpose. It has to get retained in our mind. It has to get retention. There must be retention of the particular movement in our mind. Okay. So retention can only be achieved by the sensory integration. Okay. So sensory information is a feedback process which can be intrinsic or which can be extrinsic. So intrinsic means self-evaluation. Supposingly, when I ask the patient to lift the mobile, he find it very heavy that he doesn't have a muscle strength to lift a 1 kilo of a mobile phone. Okay. So this is a self-realization, or it can be augmented. Now therapist is an augmented process. Supposingly if he is able to lift the process, I'm giving him verbal commands. I'm telling him your hand is going like this, it should go in front. Okay, your joint position is not right while lifting the phone. So this is the sensory integration which we give to the patient, or patient can get it from themselves. The particular task is learned and adapt. So all three are clear now: sensory integration, motor adaptation, and motor learning. So that's why the approach is called sensoromotor adaptation and learning approach. So on a particular movement, we have to evaluate the patient, like what movement, what muscle is inactive or is not working properly, and we simultaneously start the process. And the beauty of this approach is learning, adaptation, and sensory integration can work together. It can be side by side. You don't need to separately train them. It can be side by side. You can tell perturbations, you can push the patient, you can make them aware, you can ask them to learn this pattern, you can change the task. So this, you are developing the patient's movement. Okay. So in the conclusion, I just like to say, like in a critically ill COVID patient, we have, before that, I just want to show you a video of a patient. Okay. So Dr. Komal, just tell me, is it working? Are you able to see the video?
We can see the folders, but we cannot see the videos.
Video is not coming.
The video is
Sir,
not
it
coming.
has not started.
I'm
Just,
sorry.
so it has not started. Just click on the video.
Just a sec. Okay. Now, is it coming?
No, sir.
Can you see the video? Okay, so I'll just describe it. Like I have a patient for swine flu, and we have rehabilitated the patient in 60 odd days. So the case was that there was no ankle movement, there was no knee movement, and we are training in this video. We have given a walker to him, and he is doing a sit to stand activity. Okay, so and we are having two therapists there holding the patient so that at least he can do the job, and we are making the patient aware about how to sit and stand. Okay, uh, I'll just try one more time. Is it coming now? Can you see it now?
Yes, sir. It's coming.
Okay, now, okay, see. So I'm holding the walker, my foot is on his foot, and I'm asking the patient to sit to stand. Okay. So as we can see, the patient has frailed up. There's a tracheostomy tube here. This patient was on ventilator. He was on an ECMO device, and he was there in ICU for 1.5 months. But in 60 odd days, we have asked the patient to lift his back and up, okay? And there was no pelvis control. So what we are doing, we are asking the patient to stand up with the walker, and then he will do his pelvic to and fro motion. So with this, I am training his trunk to be straight enough, right? And this was done continuously. This was done on a certain period of time. And now, after this, there's one more video. Now, after this, can you see this video now? So after 10 days of the repeated motion, we were able to achieve. Can you see this video?
No, sir.
Uh-oh, okay. Now?
Yes, sir. It's coming now.
Okay, so now the same patient after practice, he is independently lifting him from the chair. At that time, he was on a walker. We were supporting him from the foot. There was no control of pelvis. Now with the adaptation process, he has learned to get up from the chair. Right? Now,
Yes,
there is second example. Supposingly, I want my patient to start the stairs, and I know he is weak. Dr. Komal, can you see this?
no, sir. Video has not started.
Okay. I think I have to do it again and again. Now?
Yes, sir. It's coming now.
So we have come to almost 50 days of rehabilitation, and his quadricep muscle power is very good now. So we have started up and down, step up, step down technique, step up, step down technique, so that the brain perceives that he knows this movement. And finally, on the 60th day, we were able to, he was able to actually climb the steps. Dr. Komal, started?
Video not started.
I think he wants me to do it twice. Okay. Now, now the patient
Yes,
is
sir.
actually climbing the steps. Okay.
Yes, sir.
So this is the beauty of this sensoromotor learning approach. We make the patient aware about his condition. We make him aware about the sensory approach, and then we start the adaptation process. Right? So in the end, I would like to conclude that why this approach can be helpful, because as I said earlier, that there is critically ill polyneuropathy and there is critically ill myoneuropathy. Okay, so when both is there, so we can use this approach as an implementation is required over and over to achieve the optimal functional recovery in the motor function. So this approach may be helpful in bringing the optimal function in critically ill COVID patients. Thank you.
Thank you, sir.
I hope I was not fast.
No, sir.
Okay.
Uh,
So, yes.
sir, there is no question, but I want to ask you that इसके अलावा हम किसी और कंडीशन में भी इस अप्रोच को यूज कर सकते हैं, क्योंकि अभी तक हम न्यूरो केसेस में ही ज्यादा यूज करते थे, तो आईसीयू में हम इसे और किस कंडीशन में यूज कर सकते हैं?
See, neuro clearly, as I said, the paper has been published for neuro case only, right?
Yes, sir, I have
मगर
seen in
हाँ,
neuro cases.
या बट जब आईसीयू के अंदर हम रहते हैं एंड आईसीयू का प्रोलॉन्ग पीरियड ऑफ टाइम रहता है हमारा, सो वी आर बाउंड टू गेट दैट वीकनेस. सो
Okay.
दिस टेक्निक कैन बी यूज इन एनी आईसीयू केस which is coming from ICU from longer time period.
Okay.
Okay, supposingly a patient is in acute exacerbation, he is having a COPD, but he was on ventilator for 5-6 odd days, then he was in ICU for 15 days. Even in that particular patient, we can use this technique.
Okay, sir.
So to bring out our optimal results. So we have
Sir,
already have a WhatsApp group. Is there any questions you can ask me, or there
sir,
is a
one more
email also?
question is asked
Yeah.
that critically ill have respiratory distress or dyspnea. Does it affect the sensory motor training?
Come
That
again.
respirate Sir, critical patients have respiratory distress and dyspnea.
Yes.
Then does it affect sensory motor training? उसकी वजह से कोई इफेक्ट होता
See,
है?
obviously effect padega. Like you need to solve that parameter first. A patient need to be trained for the lungs. A patient lung optimal function need to come before you can start this process. Yes. So you can treat the lungs separately, then you can treat the muscles separately. If the see our oxygen is our energy source, okay,
Okay.
and if patient is dyspneic, that means the oxygen level is low, okay, and he will not get the energy for doing a particular movement. So you need to resolve that oxygen level integration first, and then you can start the myocardial. But it is not a long process. Even if in the oxygen part you can start some movements, and then finally, if the problem is resolved, you can work in on this level. Because this patient, I told you that he was already on ventilator and an ECMO device. We weaned him off. We started gradual mobilizations, and then this approach was applied on him.
Okay.
Yeah.
Thank you, sir. It was very informative session. We like your webinar.
Thank you.
Now I'm handing over mic to Dr. Priyanka Rani for a vote of thanks. Ma'am, are you listening us? Dr. Priyanka?
Yeah, I'm listening you. Can you hear me?
Yes, ma'am.
Hi everyone. I am Dr. Priyanka Rani.
Hello.
Hi. Thanks, Dr. Veena Kumar, for sharing your knowledge with us. The webinar was really informative, and my special thanks to IAP Central team, IAP myself for organizing these type of events. And the last, I would like to thank Dr. Vinod Kumar Kaushik, the IAP technical team, who always support us and make these events successful. Please like and subscribe our IAP India YouTube channel also. Thanks, everyone.
Thank you, ma'am.
Thank you, Dr. Priyanka and IIP Women's Health for having me here, just to share some what we are doing right now. And thank you for the
Yeah.
opportunity. Thank you.
Thank you, Dr. Vino.
Thank you. Thank you, Dr. Kamni. Thank you, Dr. Komal, for moderating the event. And you were really great on
Thank you,
this.
sir.
Thank you.
Thank you, sir.
Everyone, thanks Dr. Veena Kumar, and thanks to all that moderator and the team members for organizing this wonderful webinar. I just shows gratitude towards again Dr. Ruchi Vaishnav, ma'am, IIP Women's National Head, and Dr. Sanjeev K. Jha, IIP President. I just want to tell you, just subscribe IIP India YouTube channel, and we are also on that. The Twitter account is also there, IIP India. Facebook page is there, IIP India. Okay, thanks a lot.
Thank you.